I'll go ahead and get started. Thank you so much, by the way, for the invitation to be here. It's an absolute pleasure. You know, starting off as a therapist, it's a little bit like being thrown into like the middle of the forest, and you have to kind of find your way out. And you know, by the time I think I'm getting down to the edge of the forest and feel like I know what I'm doing, I would say there are no right and wrong approaches. There are just good and bad approaches, and the fit is the most important for your child. But I'll tell you a little bit about myself. My particular journey was started in the mid-1980s at Vanderbilt University, first seeing clients as part of my training. I was in a pediatric facility, part of the medical school, working alongside psychiatry residents and pediatricians and other psychology folks who were in training, a psychologist as well, social worker. It was a real nice multidisciplinary team approach. And we would see children with all sorts of issues. And I noticed even from then, back in the mid-1980s, that it seemed to be more boys than girls being referred to that clinic, but not very disproportionately. And I also noticed that there was an interest, because I'm a boy therapist, something special about the Y chromosomes, that a lot of little boys, if they knew they were going to see a therapist, really wanted to see a boy therapist, particularly when they were a little older, maybe from 7 and up. That was like a big issue for them. So over the years in the clinics I worked in and the various places that I eventually not just trained in, but then supervised other people, I would see more and more boys being referred to me, as well as some of the male therapists that were in the profession. I started a private practice along with that, and just the number of boys just seemed to grow over those, 15, 20 subsequent years. And it was starting to bother me, and I thought, well, maybe there's a referral bias. Maybe it's, well, you just have gotten known as a person who treats only boys. Well, it turns out there was a bias, and it was a national bias. So I dug deep and I looked, and that's in part what led to this book, which is I found that in terms of the psychiatric diagnosing and medication use, predominantly it's in boys in the United States. And we can maybe go through some of the statistics, but they're the types of statistics, suffice to say, that just sort of open your eyes and make you ask, well, why? And I began to wonder, is there something inherently wrong in boys, or boyhood, to explain why, 2 to 3 times more boys on average are diagnosed with ADHD, which has become the #1 pediatric problem in America. It's actually 6 to 8 times more if you're looking at clinics and counseling centers. Dramatic. So is, Asperger's, autism, and even in pediatric bipolar, it looks like in the medications and diagnoses tends to be slanted toward boys as well. Well, is there something wrong with what's between their ears? Is there something wrong with their brains? And that is what the psychopharm movement, which has done some good, but in a lot of ways I think it's done a lot of harm, has been teaching us. And I've been a part of that problem for many years, being a part of large pediatric facilities and departments of psychiatry myself. And so when you look and you see the disproportionate numbers, you have to ask, this can't be. And then what I did is I started to look at development and how the boys were different from girls. And I kind of ran into sort of another roadblock, which was, well, we've done a better job with trying to level the playing field in gender. Should we start to treat boys so differently and try to look at them as having special privilege in early schools because they're not learning as fast? But if you take that whole argument aside of gender differences and just look at what boys versus girls need as groups, and is what individuals within those groups need, it became clear that their development was markedly different as a group than little girls. And in educational settings is where these diagnoses are first likely to pop up. So that's what led me to move toward writing the book and talking more and more about the very simple types of therapy techniques I use, cognitive behavioral therapy. I could teach you how to do it in probably 5 minutes. We'll choose a disorder. I could break it down for you. They're not complicated. The application of them is what makes it complicated, knowing when to use them, when not.
Thank you. Well, as Lois was referencing before, my background was as a performer, as a dancer, and in the theater. And in 1979, I was injured and couldn't dance anymore. So I went to a teacher's college where they were giving full scholarships to people who were interested in creating arts and cultural programs for children with special needs. I had been working at the New York State Theater with Jacques D'Amboise and the New York City Ballet to teach dance to deaf boys at the time that I was going to school. So I began to do exactly that. I began to create cultural programs when I left Teachers College. I didn't really want to be a teacher. I really wasn't that interested in teaching anybody anything. But I was, I was at a crossroads of my life, so I got a free ride, so I thought, I'm taking it. So I started a theater and dance company for deaf boys in Westchester, and we toured around, and I began to work for BOCES, which is, I forget what the initials stand for. But it's a special ed resources and training for children with special needs. And luckily enough, when you're in special ed, or when you were then, as a teacher, you could do pretty much anything that you could really get away with. Because nobody was really watching you. It was freer than the general education system. You were in that classroom by yourself. So I did very unusual kinds of things. With the deaf children, they could barely read, and they wanted, because they were freshmen in high school, they wanted to do what the other kids were doing, which was read Romeo and Juliet in your freshman year of high school. I'm like, okay. We decided we were going to read Romeo and Juliet. And they had no idea what they were reading, and they were speaking, and they were having a lot of speech. And we did performances of Romeo and Juliet, and we watched the movie, and they went home, and we're doing Romeo and Juliet like everybody else. And I learned something very, very important from that experience, is that when you have some kind of disability, how the world relates to you dramatically alters your life. The disability is one thing, but you are no longer related to as a member of a speaking, hearing, thinking, creative human community. That politicized me, because this is a political issue of what is happening to our children, where you have a young boy that I saw a couple of years ago who was 4 years old, was labeled as autistic, and what we discovered in the course of the therapy was that his mother had been told, he's not relational, autism, you don't really relate. He doesn't understand, he doesn't feel empathy for other people. This is what she was told in her evaluation that she received for her son. And in fact, what she had, in the course of the therapy, we discovered the enormous impact that that had had on her. She had stopped really talking to him. She talked to him, but not in normal human discourse. She would say, don't do that, or hi, very short sentences. By the time he was 6, he barely could speak. He perseverated a lot. I gave him a lot to talk about. He kept saying the same thing over and over again. And just a quick story, I think will help you learn more about how we work in social therapy as a group therapy that focuses on the development of the relationship and the development of the child. So he comes into the session and he says, I'm a big boy, right? 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 He did that for a very long time. And his mother said, stop him from doing that. It drives me crazy. So I said, it doesn't really bother me. I repeat myself. I told him I repeat myself, and people find it very annoying. And some people don't. Right now, I am not annoyed with you. He kept going, and she was like, you don't want to stop him from doing that? Can you help me stop him? I am not interested in stopping anybody from doing anything. I am interested in creating an environment where this child and his parents are able to create something together. So I think what is unique about the approach, this may sound very, I don't know what. I'm not interested in teaching anybody anything. I'm not interested in molding. I'm not interested in shaping. I'm not interested in pointing in the right direction. I'm interested in creating something with children and their families that has to do with who I am and who they are. That is a meaningful activity, and as it turns out, if you get good at that, it's curative.